Hello everyone, welcome to another video of this revision series. In this video, we will talk about antiarrhythmic drug. Before we go to the drug classification, the normal rhythm pattern of the cardiac tissue, that is the action potential in normal atrial or ventricular cardiac muscles or in Purkinje fibers. We should first discuss this. So, suppose this is a curve showing the action potential in the atrial, Purkinje fibers or ventricular cardiac cells. The resting membrane potential in these non-autonomic cells, these are non-autonomic cells, lies near minus 90 millivolt. And in these myocytes, the action potential has 5 distinct phases. Phase 0 is called rapid depolarization, phase 1 or early repolarization, phase 2 or plateau phase, phase 3 or rapid repolarization, and phase 4 called diastolic depolarization. So, in normal condition, the diastolic depolarization persists, that is the resting membrane potential, and from this the action potential will generate. So, phase 0, which denotes the rapid depolarization, this results due to sodium entry into the cell or myocyte through the first inward sodium channels, and the cell membrane's electrical charge changes from minus 90, that is from more negative to less negative, and gradually it reaches 0 and then finally to the positive value or plus 30 millivolt, and whole this process is called phase 0 or rapid depolarization. And this interval during which the myocytes cannot be stimulated is called as absolute refractory period, when from phase 0 to phase 3 no stimulus can be further gained by the same myocyte. Next, phase 1 or early repolarization. This small part is the early repolarization, and this is because at this stage, as voltage gated sodium channels close, potassium channels rapidly open, and the cell therefore rapidly repolarizes. This produces a spike and a dome configuration of the action potential. This is called early repolarization. Next, the plateau phase or phase 2. At the end of phase 1, the voltage sensitive L-type calcium channels open. So, now it causes slow inward current. This is then balanced by the slow potassium current from inside to outwards, and almost this makes a balance because 2 potassium ion balances entry of 1 calcium ion, and thereby the cell membrane's electrical activity is stabilized temporarily and the action potential reaches a plateau phase, and this is preceded by a notch at the beginning of the plateau phase. This is a notch. And next, the phase 3 or rapid repolarization. At this phase, calcium channels close and potassium channels open. Potassiums are pumped out of the cell in a higher rate than calcium. So calcium entry is almost close and potassium exit is facilitated. So it soon resumes its initial negativity, that is minus 80 millivolt, and ultimately it reaches the normal resting membrane potential or minus 90 millivolt. And also in this time, the ATPH pump that causes entry of potassium from outside and exit of sodium from inside by a pumping action, and all this maintains the resting membrane potential of the myocytes. Last, the diastolic depolarization. In this phase, the ion balance is returned to normal, and it is caused by again sodium potassium pump which actually stabilizes the membrane potential. Outward potassium current always persists because potassium channels are sometimes leaky potassium channels, and sodium calcium ion exchanger also removes some calcium from the cell. So these three channels, sodium calcium exchanger, potassium channels, and always the sodium potassium ATPH pump, these ultimately maintains the resting membrane potential, that is minus 90 millivolt, or this phase is called diastolic depolarization phase. Now if there is any abnormality in this pattern, in this normal action potential of the myocytes, then arrhythmia will generate, and according to antiarrhythmic drugs has been organized. Like there are 4 types of drug. Type 1, they are mainly sodium blockers, and there is also subclassification 1A, 1B, 1C. We will discuss this one by one. Type 2 are mainly beta blockers. Type 3 are mainly potassium blockers, and type 4 are calcium channel blockers. And some miscellaneous drugs like digoxin, adenosine, magnesium, potassium also act as antiarrhythmic drug for different types of arrhythmia. Class 1A drug, they mainly act by slowing the rate of rise of phase 0 by blocking the sodium channels, because type 1 drugs are always sodium blockers, so there are various sodium channels. So in this case 1A drugs, they slow the rise of phase 0 or rapid depolarization, thereby they also increase the effective refractory period and prolong the action potential duration. So this group of drugs are used in some conditions like ventricular tachycardia mainly, and they include quinidine, procainamide, diisopramide, etc. Class 1B drugs, they shorten the phase 3 repolarization. They shorten this phase. As a result, they also decrease the effective refractory period, and they mainly block inactivated sodium channels, while the class 1A drug, they mainly block the open channel, but in this case class 1B, they mainly block the inactivated sodium channels, and they include lidocaine, phenytoin, mexility like drugs, and mainly used for ventricular tachycardia or ventricular fibrillation. Also they may be used in digitalis induced arrhythmia. We will discuss this. And class 1C drug, they markedly decrease the rate of phase 0 depolarization in Purkinje and myocardial cells. So if we now discuss these drugs, and in many types of arrhythmia like atrial flutter, type 1A drug has no role. Also in atrial fibrillation or PSVT, there is no role of these type 1 drugs. They are mainly treated by type 2 or type 3 drug. Type 2 drugs like which are mainly beta blockers, propranolol, esmolol, they are effective in atrial types of arrhythmia, that is atrial flutter or atrial fibrillation. Also type 3, that is potassium blockers, amiodarone or dofetilide are effective. Type 4 like calcium channel blockers like verapamil, they are also effective, and some miscellaneous drug digoxins are also prescribed. For PSVT, type 2 like propranolol, esmolol, type 3 like amiodarone, and type 4 like verapamil, also diltiazem are effective, and sometimes digoxin or adenosine like miscellaneous drugs are prescribed. For ventricular types of arrhythmia, that is ventricular tachycardia and ventricular fibrillation, here 1A or 1B drugs may be effective, but type 2 drugs are not actually prescribed here. Type 1A like quinidine or procainamide are prescribed effectively in ventricular tachycardia, and 1B like lidocaine are also prescribed. And type 3, that is potassium blockers, sotalol or amiodarone may be given, and some miscellaneous component like magnesium may be prescribed. For ventricular fibrillations, lidocaine is very effective. With type 3 drug, bretylium and amiodarone, they are mainly potassium blockers, are given. For WWW syndrome or Wolff-Parkinson-White syndrome, type 1C drugs, here only type 1C drugs are used, which decrease the rate of rapid depolarization, like propafenone or flecainide may be prescribed. And type 2 like propranolol or type 3 amiodarone sotalol are also prescribed. For torsades de pointes, type 2 drugs are mainly prescribed exclusively propranolol along with some effect of magnesium in miscellaneous group. Digitalis induced arrhythmia, in this case type 1B, that is lidocaine or phenytoin, that mainly reduces the effective refractory period by blocking the inactivated sodium channels, are prescribed. Along with type 2 like propranolol, they are mainly beta blockers, and some miscellaneous like potassium supplements are given. So this is all a very simple version of antiarrhythmic drugs, mainly focusing the normal action potential generation in myocytes. Thank you guys for watching.